That's great. Well, let's just jump right into it then. So, Gabriella, Cardi, Veronica, Gabor, thank you so much for coming. I think I've at least talked to all of you. My name is Bryden Blackclouds. I'm an emerge doc in Powell River, and really happy to be sort of spearheading this Resident RTVS Rounds. It's sort of our goal to make this a pan-provincial thing for all the residents in BC. Whoever comes will see, but we're hoping to record it and have it accessible to people later. One of the big reasons for this is that a lot of residents don't get much exposure to rural BC, and so we want to provide more exposure to residents of what being a rural physician is like, what are some issues that face rural physicians, how can you get support when you yourself are practicing rurally, either as a resident or as a staff. So yeah, we just want to open the door to not only some insights into rural practice, but also into a whole bunch of support resources that exist for you when you go rural, and just get the perspectives of people that don't only practice rural, but practice virtually as well, like Dr. Mayer. So Anton, it's a pleasure. I'll let you introduce yourself because I don't think I could remember all the hats you wear, but you've been a very busy man in leadership and medicine for a good long time here in BC. So I'll pass it over to you, sir.
Sounds great. I'm meeting you from the beautiful unceded territory of the Silix people in Lake Country, and I practice in Fort St. James, that is part of the Nacasli, Binshi, and Glaston Witan people. So very happy to speak to you about or from that land-based approach. It means a lot to me. I'll share something more about myself, but before I continue, would you be comfortable for us just to continue, and as you speak or will ask questions when I'm done with my initial input, then we introduce ourselves as we speak, or do you want us quickly to go around the table and just share something? What would make you most comfortable? And we can do it either way. So if you want to do an introduction now, just speak up. Otherwise, I'll just continue. And from there, we'll see how it goes. Does that sound reasonable? Awesome.
Yes.
So I'm going to start screen share, and then you'll see me what you see on the screen. So let me just quickly go through that. I'll just need to connect to something different here. Give me a second. It just did take the PowerPoint out. I think I've got it here. Give me 1 second. Now the screen share probably would work better. Can you see in front of you just the general template currently?
Yes.
Yep.
Okay, so now I'm going to go to this. Do you see the full PowerPoint slide, or do you see presenter slide in front of you?
We're seeing presenter mode.
Okay, so let's go to the full one. That would be better. And do you now see the full slide deck in front of you?
Yes, we do.
Yep.
Yep. Looking great.
So, so let's share with you this. The story that you see in front of you is a photo of Fort St. James. Against those cliffs are, as far as memory can go back, the most beautiful rock paintings of an ancient people. And I came to Fort St. James in 2011. So I'll use the story of Fort St. James to tell us more about rural, to tell us more about team-based care, which actually is the one that I thought might be appropriate, and then tie that into RTVS, but specifically also touch that and connect that to leadership. So I'm a clinical associate professor with UBC and UNBC and 7 other universities across the country. I am the co-chair of the General Practice Services Committee, which is the physician co-chair with the Minister Ted Patterson. And it is one of the collaborative committees that is negotiated through the Master Service Agreement, and it is the one that pays attention to family physicians and primary care reform, and blessed to be in this position. I'm a full-scope family physician that's doing generalist work, and means that my heart lies around longitudinal relational continuity and the beauty of that. I am also in real-time virtual support, rural urgent advice doctor for the RUDI program within the RTVS, and I'm rurally community-based. And I'm finding myself in a space in my career that I thought came about 5 years earlier than most of us would ever step into roles like this, where I am transitioning into, in this case, senior medical leadership work. That kills me. And what I mean by that is this transition is taking me away of my cocaine of more than 30 years of my life. That my life was involved in clinical care delivery. And so that transition is still hard for me. I've got wonderful family that helps me with that, but I many times wake up when I now have 16-day hours. This morning started 6 o'clock with that, with meetings around the vaccinations and the rollout with Bonnie. And I wish I could have been in practice at the same time. That the ability and the opportunity to make change is something that I find valuable. So I receive an honoraria to attend today from the RTVS program, including a bit of preparation time. I have no industry bias. You now know that I hold the academic appointments as well as a RUDI contract. So what we're going to do today is we'll try to bring some learning objectives into this. It's a community reality that I try to show you, and a story, and then hopefully we'll have some time to have dialogue. So I'm really humbled to join you today, and thank you for choosing this beautiful profession. Your journey of your own learning and your young leadership career has probably been surreal during this last year. And this little bug came in and impacted all of us in a way that maybe none of us would have contemplated to the extent it does. I really hope that you and your family and your loved ones have been safe during this time. I want to thank you for your commitment to engage in places like this, where we have an opportunity to touch each other's soul. So in terms of that, just maybe something that I can share with you. As a family physician, when we are in the ER, when we do full scope, it's exciting to resuscitate on a patient, exciting to deliver a baby. For me, the thing that excites me most is the opportunity to touch the soul of my patient, or being touched by my patient. Or in this case, when we have dialogue like that, the true meaning behind all of that. We'll do a little bit of dialogue around team-based care in the Canadian setting, BC landscape, share with you some thoughts around the benefits of working in a team, collaboration, wellness, grace, how we show up, enablers and support that help us, like the RTVS that we will discuss today, real-time virtual supports, and then also a bit of the Fort St. James story. So when we describe team, there are conventional definitions of that. It is where we collaborate from a patient and family experience around shared goals, and then find a way on common ground to begin to execute on whatever we decide would be important to us. There are various teams. A team would be 2 people. A team can be 50 people. I'll tell you later the story of Fort St. James. In the year 2012, there were one physician, and there were 7 support staff in the health environment. Today, in this small town, there are 9 physicians, 4 nurse practitioners, 54 support staff, an exponential explosion. That is still a team. So as a family physician, what role do we play? Let me early on introduce this concept. The ability to lose hierarchy, to become kind, humble, create safe spaces, be self-aware, to be mindful. That is what I would tell you would be the role of the family physician in a team construct. That does not mean that you lose strength in leadership. Never misconstrue humility and kindness with losing strength. It is how we use that gift when we do speak as the specialist in primary care. That is what you are becoming. You are becoming a specialist in primary care, something to be very proud of. How do we use that in a non-hierarchical way? Physician versus nurse or other team members led. When we deliver the care, let's focus on that longitudinal relational continuity, the comprehensiveness of our profession in a coordinated effect. If I look, you see there in front of you a picture of Nakasley, one of our outreach First Nation communities, in this case an urban reserve in the town of Fort St. James, is an example where when we started building our team and created interconnectedness and integration, that we understood that what happens in one place has an effect on the other place. And we should not duplicate or replicate. And unfortunately, we live in silos, most of us, when we do these things. So the team brought this opportunity that we could do collective impact principles. We could look at chronic disease in a different way. We could look at our care from a social determinants of health lens. We live in a new world where we have a social construct that pro-poor and pro-vulnerable is just part of our being. You as a young generation is taking us to that place of higher moral compass. That's what I at least experience. That's what excites me, because those might be values that I've been blessed to have been exposed to all my life. And so now to see that a society is thinking like this, and a young generation of physician leaders is just beginning to push us more into that realm that says the social determinant of trust might be the most important one that we have not yet discovered collectively, how important that might be. That's the story of what I share on this picture with you. So the benefits of team-based care is something that we all understand intuitively at this level. You all come from a pre-academic career. You've all been handpicked and selected where you are now. It is the expansion of access to care. That's the usual thing that we see. And then it's the efficient use of resources, the continuity of care, the longitudinal relationship, and then the improvement that is there that we can measure in an academic, scientific, best evidence practice way. The PQI practice, quality improvement, the simple levels of how do we grow on this journey, and are we making an impact and making a difference. So the typical thing you're going to be confronted around team-based care, for the ministry in the agenda of the primary care reform ahead of us and the era of team-based care ahead of us, where we now sit from a collaborative table advantage, as I just explained in the beginning. Most have been focused on attachment. And so I'm trying to change the dynamic, that it is not just about attachment. It is about the access principle. Yes, Minister, let's meet your agenda of an urgent primary care clinic that is a political beast where we have nothing to say about it. You're going to live this a lot in your division structures, which I'll touch on as we go. So let's give it to you. But that's not attachment. That is access. Let access lead to appropriate attachment. Let the attachment take us to the holy grail, which is longitudinal relational continuity over time. that Barbara Starfield showed us without a shadow of a doubt in Johns Hopkins for more than 23 years of research, that none of us have ever need to duplicate that. Yes, and it continues. We are doing still continuous work, and every time the answer is the same. The relationship between a patient and a family over time to a primary care home and a family physician, or like a nurse practitioner, a most responsible physician, has been proven without a shadow of a doubt to be the most potent prescription of any medication we can give everyone. In fact, 65% improvement versus placebo. And if that has changed lives, saved lives, prevent disease, changed outcomes, and even led to improvements in the disparity among disadvantaged populations, which is a lot of our social construct. So working in teams, we scanned, literature scan. I am blessed to do a project for RCCBC, the Rural Coordination Center, a large project, more than $1 million, where we do quality team-based care for British Columbia. Our environmental scan in North America showed us only 54 recent articles from 2010 that has looked into this. How do we show up as teams, and how can we work better together, and what are the essential elements of those? And there's only 2 of those articles that actually spoke from a health perspective. One was a nurse practitioner program in the north of Quebec, and then the other one was a midwife program. The rest is outside of health. And here's what we've discovered. Lose hierarchy. Be comfortable to create safe spaces for healthy dialogue and engagement. Situational awareness. I'll tell something now about that. Mindfulness and adaptability. Be courageous and brave in your conversation. Be transparent and be supportive to each other. Shared, compassionate, collaborative leadership. That's the thing that I want to share with you. How will we show up as physician leaders in the era ahead of us in a collaborative landscape? Creating a learning culture. I call this something different in my world. I take a learning system and I mix that with thought exchange, and I challenge us to begin to think about a learning exchange when we engage. And then shared commitments to values and roles. So that takes us to this incredible, incredible privilege of leadership to shape the story of the kind of influence and value I hope that we will be like to be remembered for. So it is important to understand situational awareness. When this question was asked to 75 of the world's most top CEOs by the Stanford Business Chamber recently, 99% of those top echelon answered with one voice, self and situational awareness. That's the most important element that they thought we should have to affect change. So when we show up as a collaborative team partner, I would tell you that consistently my experience has led me to a place that self-consciousness and awareness at every step is important as we build relationships and work towards trust. You and I will need to understand that it's a duty for us, to create safe spaces and a culture of healthy collaboration that will come out of those relationships. I need to tell you, this will not be a simple journey. You're gonna be burnt out because of what we just discussed here if you elect to go on this journey of self-sacrifice. And that's the profession that you chose. And I tell you here, it is beautiful. But it will not be simple. When you show up, the word grace comes to mind for me. Can we be humble enough? Do we understand what humility and humanity means? Will we be decent? Will we be kind? Will we be patient? Will we persevere? And will we not be shy to have strength in leadership? Giving ourselves and each other the patience and the grace to learn and grow together on this journey of healthcare transformation is something that I wonder whether people have spoken to you about. You are so entrenched in your academic curriculum. This might be something that I'm challenging you to think differently about, because it's going to play a big role as you move forward in your career. Here comes the bummer. We all preach this world of physician health and wellness and safety, but you're going to write me emails about burnout and then we're going to talk about resilience. So an elder recently, in a special moment, Roberta Prince said this for me: if we are unwell, we spread our unwellness. And I love to keep it in the negative. We all know if we're well, we will be okay. Remember this. From a place of hurt, if we do not have the grace to take us out of that, we might spread more hurt. The time that it takes me and Ted Patterson to spend on relationships and the way people hurt each other, where a mid-manager at a health authority level, as well as a community frontline physician, becomes wrecking balls of great ideas and miss the point of how it can be implemented, is something that we live intensely. Remember what I shared here with you for yourself as a person and also in your career as a physician. So for me personally, when we talk about resilience and how do we get better, we can be trained for that. I'll give you the example now. For me, burnout is therefore not about increasing resilience. It's about fixing the system. And then I challenge you today, we are the system. Don't start with a person across from you. Understand it starts with us. And resiliency is something I can stand up and get up this morning and I can run 3 times around the block and I can do 10 push-ups and I will get stronger, and that is part of resiliency. You can train yourself in the career of health and around resiliency. Burnout is something different, and it's about fixing the system. In that process, remember to care about yourself and to care about others as well. Here is an interesting thing that I've been working on for a new project, and that is personal health records in the digital health landscape that is getting, and so now I'm beginning to take us a little bit to the RTVS stuff. Busy slide, but here is powerful stuff that is there. The words, it took us 3 months to begin to reshape the words around this. So primary care support, community wellness, allied health, facility-based support, that's the acute care piece, specialist, that's part of this journey with us. And then in the center is the patient and the family and the care providers. And how do we get the relationship among all of this as we design everything that we do? So this little petal of power that I call it is something that is actually has got a much deeper meaning, but I'm not going to spend too much time on this today with you. So now we go to the hard stuff that most of us check out. But so when we do this team-based care culture, and we take all the values that I tried to share before, and we now talk about an EMR and a patient health or a personal health record and all the telecommunication tools and the methods that's there. The slingshot of 10 years ahead of us through this little buck that came and exponentially advanced the virtual care arena and all its complexities, where the most important one for you would be appropriate use of that. When do I know to be doing an in-person visit that my patient and myself will be safe and I won't miss things and just send people and offload them? So this is now a world where I think you can teach us more. A world where you have a lot of insight and how electronic media and tools can help us. And just with one word, I'll say any of these. And specifically, let's talk about virtual connections, which can be a telephone or a video. In my world, is just a method to a means. It means it is only a stethoscope that we've designed. That stethoscope will help us to assess something and hear the heartbeat behind that and understand what does that mean to us. And we still need to interpret. The machine won't do that for us, even if artificial intelligence is here to stay. Just a reminder of this. So in this world, we've designed real-time virtual support programs. And the group that talks to you today, from Bryden and myself, we live this intimately. In the case of RTVS, it's about rural practice focus, avenues for training, learning, getting together as a team. A home care nurse can speak from a front line to you. A nurse in Thatcher or Binche or Middle River, 110 miles from your core practice, sometimes across the province from where you take the call, can connect with you. The initial discomfort of treating complex cases. Where do I send the patient back to an ER? Do I have a place of bricks and mortar? Do I need one? Does the patient have transport? If I do tell them you need to be seen in person, and understanding that from Yakuchi to Fort St. James on a road that will take you 4.5 hours, if I need just an X-ray for a patient that says, I've got this pain in my arm and I fell last night. So let's quickly take an X-ray. What is the appropriateness of this? Is there a reassessment? What's the safety in that? So virtual community of practice, learning from people like Bryden and myself. How beauty of that dynamic. There you have in Bryden a young, fresh, beautiful mind, skilled, so skilled. And here you have an old fart like Anton that tried to keep up with my own skill to stay in that world. But I'm also a Rudy doc. I might bring something different sometimes. And so that's the virtual community of practice, how we help each other. And I can teach and Bryden learns something from me, but he mentors me as well. And he does not even sometimes know that. Learning health systems is important. Sustainable practice, recruitment and retention, how these supports that's now available to us make you as a new to practice and young physician more comfortable to know if I go in there, I do have supports that I might never have had before, and they are beautiful. And then other supports like the race line that you speak to specialists, that's the kind of stuff that RTVS opens up an opportunity. This slide is very busy. It's just a pathway of how we connect and whether a nurse answers the phone line from the Heidi or Provincial 811 line, whether a First Nation doc of the day answers the line through the nursing structure of a triage that they've created for us, or whether you speak to a physician directly in the worlds of the Rudy physicians, like Bryden and I are two examples of that. It is the rural urgent doctrine aid. You speak to one of your own, maybe one that has elevated themselves to the intensity of your ongoing learning in your career that could take you to a place that you will be a specialist. Bryden is a specialist in primary care and in emergency. And so when that person answers the phone, you get this kindness, the place-based transformation that took him to a place that says, I need to help this person with kindness because I was there once. And so it's hand-picked individuals that can help and guide you, and a friendly face. The next one is Rosie, our rural intensive specialist that helps us. They are the higher level, but they are also hand-picked for this. How do you engage and show up as a leader or a learner or as someone that exchanged knowledge? So Charlie, our child and youth, as another example. We have dermatologists that's doing that. We have Northern Health Triage Intensivists, and we now have Mabel, the primary maternity and baby advice line that we have. So these supports are all available to you. And if you want to learn more, you reach out to Bryden and or myself, and there are tons of information we can give you. And you can ask questions, and Bryden and I will help to answer. So now you land in front line wherever you're going to be, in Burnaby, in the city, in Chilliwack, where you think you will be rural, but that's not really rural, I tell you, and Bryden tells you. Or you end up in the little Fort St. Jameses of the world, or then the places like the Yakuchis of the world that you go there once every 6 weeks if you're lucky. So who's there to help you? And this is what Bryden and I tell you today. this concierge service of RTVS that I just shared before. And then there will be a local medical director and a chief of staff. There will be a medical staff association structure that's been structured through GPSC. There will be a MAC committee, a medical advisory committee at a hospital where you need privileges to work. There are divisions of family practice that will help and support you through General Practice Services Committee. There is the Rural Coordination Center of British Columbia that has this community coaching for quality that I just shared earlier with you. There's Doctors of BC with its plethora of supports that you might not even be aware of. There's the health authority that can guide you. There's local community supports. There is Health Data Collaborative, the only province in this country that now has the connection across all vendors, that the information on the desktops of all primary care providers, 6,300 of us family physicians and then nurse practitioners beyond that, is available in an aggregated data set with privacy and security around that for us to learn more, do QI and go further around that. And then we have regional and provincial virtual enabled care that I said. Just this slate of stuff that's important, which the message to you is fear less, be more brave, don't hesitate to take you to rural places or more isolated areas. There is supports that did not exist 2 years ago. So experience and outcomes for us, if we go in this team-based care world, is for physicians. It will enhance our clinical and administrative supports and improve practice efficiency. It results in higher clinician and staff satisfaction, improve work-life balance, retention, recruitment. We can just keep on giving you all these things back. For our patients and our family that we care for, team-based care provides timely access to continuous, comprehensive, longitudinal relationship-based care to support their health needs and hopefully prevent unnecessary acute care visits. Barbara Starfield, in your face. What does the future perhaps look like? To prepare for this, I would say from an ability to memorize and quickly retrieve complex scientific information, we will need to adapt to even greater empathy and cultural appropriateness. Social construct, a new world that we live in, pro-poor, pro-vulnerable. Place-based transformation, connection. I'll share something now about that. From autonomous decision-making to being team players and team leaders, from sick care to well care, and how can we begin to go into the world of prevention, which I hope you train yourself for better than we did. And then obviously from periodic continuing medical education to lifelong learning, which you now by now have discovered that is the career that you've chosen. So in Fort St. James, we have a story that we tried to embark in 2012 on this team-based care culture. One doctor left. As far as memory can go back, there were times that there were 3-4 doctors for 3-4 months, 6 months at a time, then down again, all in a fee-for-service environment, and did not change outcome. I remember when we started in 2012, one physician being on call every single day, trying to keep an hospital open and see the patients. Sometimes 60 people on a day sitting on this little bench in the clinic with a nurse next to me and a scribe next to me, which was an MOA. And all I did was hypertension, ramipril, what's the blood pressure, increase the dose or decrease the dose. And wanting to change that culture when I came in, and the health authority and the ministry gave me the chance. Guaranteed funding arrangement, go into alternative payment style, and let's try to change that. From that 7 staff and 1 physician, you now know I said before 9 physicians and 54 staff with a multi-professional team in a small community, immediately 1,800, but the catchment area about 5,000. If you can, we can do it there, you can do it everywhere. There are beautiful places in this province you can go learn from. We use the principles of an appreciate inquiry. Let's discover where we are. Listen to our community, let the people need and our patients. Then let's dream together. Let's go design something that can work better for all of us and ultimately begin to deliver. So I get goosebumps to tell you, we've moved into, just pre-COVID, a $3.5 million clinic. You need to come and see that. It will blow your mind, where this 65 people work together as a team, and we've lost the hierarchy. We are self-aware, but we have not lost the leadership and the strength and leadership from the primary care specialist. We have a voice. And so how did we use a QI to reflect? How did we build trust and relationships? How did we change the culture? Now, we've been announced to receive a $113 million hospital, and the spade will be in the ground within 6 months. That's amazing. You can change the places that you live and work in. So now I'm going to stop screen share and start something different. And I want you to please just engage or allow me to show you something different. And hopefully this will show up in your screen. Let's see if it's there. Not yet. I'm going to try to share screen again. There we are. Tell me, and then you need to listen carefully. The sound is not so strong. 4 minutes of your life. Can you see the screen?
Yep, we can see it.
Okay, so let's listen carefully.
They're native or they're drinking, they can stay in pain until I get there. So these are things that are happening right now still. And I've talked to other like nurses, like solution nurses who have come in and they're like, yeah, like sometimes they ask if they're native when I'm giving my assessment. So those are things that we need to talk about because that's not okay.
One of the things that we feel strongly about is reaching out and addressing those challenges right away. When people come together face to face, there's more clarity about where each person is coming from and more understanding.
Even though I stood up there today and I told my story, it's not about me, right? It's about them. What did they get, right? Were they impacted enough to see who we are as a people from a different perspective? And that was it.
Over the last now close to 20 years in Canada, I've spent more nights on a bed on reserve than I spent in my own bed. And that irrevocably touched me.
What the primary care in Fort St. James is doing, I think, is a beautiful thing. I really do. They really are taking a look at how can they help better.
And then you hear, like this morning, the story of Ruby, and you begin to understand how intergenerational trauma has affected a person and a people.
When we understand like the root causes of trauma and how it manifests in disease and addiction and mental illness, that we can look at addressing it and helping to minimize those impacts.
Our trauma is ingrained in us, and you need to be more patient with us, right? You need to ask more questions, and you need to understand that we're not always going to share everything with you because we don't trust you.
Medical doctors, teachers, professionals, they really need to be aware of cultural safety. It's beyond cultural awareness and cultural sensitivity.
It's how people feel accessing care.
Our communities are the ones to tell us what it is that they need. The patients in these communities are the ones to say, I'm really not feeling well, and these are the symptoms that I'm feeling, and they tell us what they need.
So when we look at cultural humility, that's more about the practitioner and about just coming in, realizing that this may have worked perfectly in a different context, but in this context it's perceived as being culturally unsafe. Being able to be like, oh, okay, and be able to pause, reflect, and ask for guidance, ask for help, like how can I have done better?
In that vulnerability, where you need to let go of what you are used to, what you are comfortable with, what maybe you are trained to do or have been trained to do, actually lies what I would tell you the strength. We need to know that we need to be strong because we can show vulnerability, and too few of us understand that that's beautiful.
I think these guys are amazing for doing that, and I think that it's going to be impactful, and I think it will set a stage in medicine.
I would tell young physicians that this is what care is all about. You will receive so much more as a reward than you would ever give to anyone else.
So I'm going to start screen share again. Just bear with me for a second. I'll quickly run us through to where we were before. And it gives us, when we started, I shared with you that I'm comfortable with silence. Can you see the screen again?
Yes.
So cultural wellness for me is understanding. I had the blessing since 99 to work in 79 little small places on this beautiful Canadian land between North Ontario, the Yukon, Manitoba, Saskatchewan, and the last 9 years, close to 10 in British Columbia. And I've learned that when I showed up in Fort St. James and the health authority said to me, you need to do the SANYAS course, tick box before you can be culturally competent. And I submit to you, we will never be cultural competent. It's a lifelong journey. We cannot become competent in cultural sensitivity and humility. When I showed up in the community and then started engaging with the chief and councils and the elders and the community, they told us, we are the people of the Dene, the people of the water. We want to tell you the story of our stick and the frog and the bear. And that is cultural humility and safety training. So be careful about just tick box mentality. Len Peer, one of the young man, one of this province and probably this country's most foremost mentors around cultural humility and safety, tell us that this is a practice and not perfection. For me, it's truly a journey and not a destination. And we make the road by walking. We have lots of work to do. Let's start walking together. That's the journey for me of cultural humility and safety. Newbury said in a long time ago already, the attitude that people want these services, they have to come to the city. For me and for Newbury, simply unacceptable. Remember the story of the blind man and the elephant. Before we hear, we think we need to see. I tell you something different. Listen to understand. Listen with deep, deep caring. Make sure that in the blindness, that you try to get to a place to understand more, and that might help you. And that's for me the story of the blind, or the man and the blind man and the elephant. The story of Fort St. James is one where we had a shared purpose, where we understood the value of social justice, where we worked hard to create connection and trust and relationships. And this small scale change in a large scale framework, modern medicine is taking us more and more to this place. You can go read it from Africa to even the most advanced systems in Scandinavia in terms of healthcare. Humility, humanity, decency, kindness, strength, the stuff that I spoke before. Give ourselves and each other the patience and the grace to learn and grow together on this journey of healthcare transformation. So I've told you about how we did our own iterative PDSA cycles that I share something more about now. creating this culture of humility and safety, be part of the community. I remember the story of Gabe Cron, a young physician that went out to Middle River, 110 miles from Fort St. James, knocked on, there's about 62 people living there, knocked on door after door and being slammed in his face. We don't like doctors, we don't see you, we don't trust you. And then one gentleman opened up and said, I cannot talk to you, I'm going to go and catch fish. And Gabe said, can I go with you? And him and the nurse went on this 2-hour boat ride. And when he came back, this young man up to today preached this. That might have been the most important patient encounter I've ever had. And in that 2 hours, when they touched each other's soul, he was able to create a relationship and a level of trust. And now he go play basketball with a few children on their little court when he's there. And through that, he's beginning to change the lives of people by building trust and relationships. And we are here with a different social construct and engagement. And we'll bring our skill and our knowledge, but we will meet you where you are and where you want us to meet you. So that's the story of this little slide. I'm conscious about time. Longitudinal relational continuity, cultural wellness, data-informed care, ITRIF, PDSA cycles within the team, we are stronger together. So for me, what you are embarking on is a lifelong journey where I see a new generation of kind, compassionate, and collaborative physician and other healthcare leaders with comfort in losing your hierarchy, finding your agency with grace, not empowerment, your agency in a world where social justice, connection, and mindful place-based transformation will drive a humble and safe culture of caring for the patients and family we serve and the team members that is with us on this journey, but also for ourselves. So how do these concepts and our story relate to team-based care from Fort St. James? We all understood how hard this work would be, but we, at some level, miss actually sometimes how hard it really would be. We had to find our way to stay above the line, get above the waves, very quickly so. We had to dig deep to understand where our capacity for leadership comes from and what energizes us. Where does your capacity for leadership come from and what energizes you? How does collaborative leadership perhaps relate to your own self-care? And how do you and us allow others to support us? We don't need to be perfect, I think. Do you have to do that all the time? What strategies and mindsets have you found helpful that you would like to share with yourself and with colleagues? What does being authentic mean in your life? Are you more effective as a leader when you behave authentically? Like I have paid many times the price to make mistakes in trying to be vulnerable. And I'll tell you one thing, it made me a better person because I'm not afraid to learn from my mistakes. In fact, that made me much more stronger than the successes that I have been able to achieve. For me, it was worth it. What will be your story? So this is a long conversation that I took us all on. I hope it makes sense to you. You don't have too much time for questions, and I apologize for that. But this laid heavily on my heart when Bryden and the team asked me, can we have a conversation with each other? So that's my story, and I hope there is some meaning in that for you. So is there anyone that wishes to ask me anything that's on your mind?
I don't have a question, Dr. Meyer, but I do have a comment for you. I'm one of the R1s, and I don't think, well, as far as I know so far, we have not had such an authentic, I think, and I guess grounding lecture. So thank you so much for taking time out of your day to be here and just to kind of remind us again why we chose this discipline, because I think many of us chose it for for those very same reasons. And along the way, we tend to get, I don't know, maybe we grow some thorns or something, and then we become a little bit prickly as we get, we overhear comments from either other colleagues, or you absorb the mindsets of those around us. But it was a really nice and gentle reminder about why we all are here, why we all do this every day. So thank you for that.
Thank you, Samuel. Good for me to hear that as well. Anyone else having anything on your mind?
Hi, I just wanted to kind of share a similar thought. I'm actually in Powell River at the moment, and we'll be joining Bryden on a emerge shift in not too long. But coming to the end of R2, where we're, at least for myself, feeling burnt out and exhausted, and feeling like we're at the end of the rope, and feeling as well the overwhelming nature of what are we going to do next, and how do we see ourselves in this crazy world, especially one that's been turned upside down through COVID. I again wanted to say thank you for sharing your passion and a little bit of hope.
Thank you, Brendel. Thank you for what you do where you are, and thank you for just the way that you shared now, giving us all a chance to pause and reflect, and maybe give us strength that it will be okay. People like myself that has lived this a long time, have seen so much, have been touched by so many things. Generational trauma, trauma-informed practice takes us on a journey of, oh man, it eats you. And if we care so deeply about this profession, it brings a burden. And then I tell you, after 35 years of doing this, I get joy every single day of my life, not by just what I do, but what others give back to me. And hearing you and sharing that where you are now, you are tired. We all are. And then also hear that sometimes small dialogue can give us messages of hope is the way, in my opinion, that makes that sustainable over a career. Care about yourself as much as you care about others.
Thank you.
Virginia, did I see your hand or not?
No. I just joined.
Great. Thank you for the notes on the chat. Anyone else wanting to share anything? Bryden, this was an emotional journey, one where it sounds to me like it resonated between all of us on these Hollywood squares. So let's give a last round. Anyone wanting to make any last comment while Bryden is with us before we hand it back? Is this something that you would want to see in future? Would it have benefit of this kind of an engagement, which is a little bit different than a didactic engagement?
Very, very much so.
So we're going to give each other 4 minutes back in our lives. Bryden, over to you. You can close this up. I'll just share something finally when you are done.
I just want to thank you very much, Anton, for coming. I mean, you've been a leader in this field since before I was around, and I remember looking up to you even before I'd ever talked to you. So thanks for doing this. To all the residents, thanks for coming. Really appreciate it. We really want to keep a connection going between all of the doctors of tomorrow and people like Anton and Virginia and World Docs all over the place, and just introduce you and keep you in the loop about what's going on for supports for you when you graduate and even as a resident. So thanks very much. And Anton, last word to you, and then I'll introduce Virginia. Thank you.
Enjoy the rest of your studies. Seek the moments of joy. Thank you that you allow conversations like this. It is meaningful, probably more for us than than it might be for you, even if you perceive the opposite. Take good care of yourself, and I will see you next time whenever you want to see us, and we'll have many chances over the years ahead. You take good care. Thanks, Bryden.
Thank you. Have a great day.
Same to you. Thank you for your time.
All right, folks, do people want a break or should we keep going? Keep going. Okay, one sec. All right, so thanks everyone for being here once again. I'd like to take a moment to introduce Virginia Robinson. So Virginia is just an absolute pleasure to work with. Virginia, I don't want to butcher your introduction, so I'll let you do it. But for those of you who I have not met, my name is Bryden Blacklaws, and I lived and worked up in Prince George for 4 years, 4 of the best years of my life. Now here in Powell River with Bryn. So it's been really nice to have Bryn, and I know a number of you are hoping to get down here, and I'm going to accommodate all the requests, just maybe, so we'll see when all those come through. I'm calling in from the culmination here in Powell River, and this lecture series, thank you all very much for coming. This is only the second lecture we've done. We're hoping to build this out over the whole province over the next few months, and just to continue to connect the doctors of tomorrow with the resources of tomorrow and today, so you can get familiar with them, bring them to your preceptors, bring them to the communities, and get familiar using them. So when you're out practicing in rural areas, just like Virginia and I, then you've got some support in your back pocket and you're good at using it. So Virginia, you introduce yourself, and I really look forward to this lecture. Thank you.
Thanks, Bryden. Thanks for having me. I'm super excited to present to this group on a topic that I'm very passionate about, which is first trimester ultrasound. And I started my career in northern Quebec in Chisasibi, where I worked as a rural doctor in the very remote area, and subsequently did some emergency training and worked in emergency in a trauma center in Ontario before I finally settled on Fernie at the far eastern edge of BC. And I've been in practice for 25 years now. I do mostly emerge and maternity. And I'm sorry I missed Anton's lecture. It seems like it was excellent. But I would like to say that I also get joy every day in my practice. And I hope that continues for you as well. I don't see why it shouldn't. Okay, so I am going to share my screen and jump right in here. Actually, before I do that, can I get a quick poll? How many people have some training in point of care ultrasound? Maybe just a hand. Little bit. And how many people are comfortable with first trimester ultrasound? So it is part of the fast, but okay, great. Maybe I have something to share with you today. Okay, here we go. Can everybody see that? Okay. So to start off, I'd like to say I have no conflicts of interest other than I think you should be using point of care ultrasound on as many patients as you can, and certainly every patient with first trimester bleeding. This is not my slide. I stole it from Claire Heslop, who's an emergency physician and ultrasound educator in Toronto, but I thought it was good to share. Keep it simple, stay curious and humble. Learn from every scan. And scan everyone. And if you do those things, you'll very quickly become very comfortable with using the ultrasound to help with patient care. So what we're going to try and do today is learn how to incorporate ultrasound into the evaluation of first trimester bleeding, how to rule in an intrauterine pregnancy, and by doing so, except in the rare occasion when people have been on fertility drugs or IVF, you can rule out ectopic by ruling in intrauterine pregnancy. I'm going to talk briefly about how to measure a gestational sac and crown rump length to estimate gestational age, and also look at how to measure fetal heart rate. Okay, so if we look at major causes of non-traumatic bleeding in early pregnancy, I'm not going to be talking today about the unstable patient. So, you know, the person who has a gunshot wound to the uterus or a ski pole. You should also be using ultrasound in those cases, but that's more a trauma assessment where you're going to be looking at circulation and airway breathing. So the patient I'm going to be talking about today is one I see about 2 times a week, kind of a gravida 2, para 0, maybe their last pregnancy ended in miscarriage. They might be a little bit older, age 37, 38. They're very anxious that they're able to carry a pregnancy to term. And maybe they're 6 weeks, 4 days by certain last menstrual period. Or even a conception date. Some people can seem to give you a conception date down to the hour. So they're very aware of their pregnancy, and they're very anxious once they start spotting. So the main diagnosis that you want to rule out is ectopic pregnancy. And from an emergency point of view, once you've ruled out ectopic or ruled in an intrauterine pregnancy, you're done. You can send that person home. But as I mentioned, they might want to know a little bit more, and if you can give them more information, they would certainly appreciate that. So there's the missed or inevitable abortion, which is early pregnancy loss. So that's someone who's had a lot of bleeding, maybe has past tissue. The threatened abortion, so they're bleeding, but you don't know why. They might have a viable pregnancy, they might not. Subchorionic hemorrhage, which is a little bit of bleeding behind the placenta. And then they might have cervical, vaginal, or uterine pathology, including cancer or infection. And these are quite rare. And just to remind you then to keep in mind that these women are quite anxious, and the more answers that you can give them, the better they'll feel. And sometimes that means delivering bad news, but it's better than them not knowing. So if we look at first trimester bleeding without ultrasound, you can take a history and physical exam like you always do. And you can assess, whether they're at risk for ectopic pregnancy. Have they had a sexually transmitted infection? Have they had previous ectopic pregnancy? Do they have vaginal discharge, signs of infection? You can do a bimanual exam, but honestly, even amongst obstetricians, it's not very accurate for determining causes of first trimester bleeding. You can do a speculum exam and look for tissue at the os. That would give you a diagnosis. But most of the time, you don't really see much on speculum exam. You can do swabs to rule out infection, but you're not going to get that answer right away. You can do serial quantitative beta HCG measurements, but you won't get that answer right away either. And where I am, they don't even do it in-house, so it's a few days to get those answers. And then finally, you can arrange for a formal ultrasound. So almost all of these causes can be determined immediately at the bedside, give you peace of mind and increase patient satisfaction. And you can do it with ultrasound. So I'm going to start right in here. This is a sagittal section of the uterus on ultrasound. There's a schematic to the right to try and help you orient if you're not used to seeing these images. In the schematic, the bladder is right above the uterus. I find most of the time your bladder is going to be screen right. So your probe is at the top of the screen. Then you'll see the fundus of the uterus, and deeper, you'll move to the cul-de-sac. So I'm going to show a short video. It's about 1 minute long. Okay, hello, we're going to do a first trimester ultrasound today. You should start with lots of gel. And tip number 1, you want to start at the symphysis pubis. So you want to put your hand right down there on the bone. If you start too high up here, you'll end up in bowel, which is kind of the wilderness, and you'll get lost. So if you practice maternity, you'll be used to doing this. You put your fingers on the symphysis pubis, and right over there is where you put your ultrasound. I'm going to start in longitudinal or sagittal section because I find the anatomy is a little bit easier to see. And once I see the bladder and the uterus and it's central on my screen, I'm going to fan out one side to the patient's right and come on back through the uterus and fan out to the patient's left. Once I have a nice sagittal view, I will then rotate my probe 90 degrees. Now the marker is going to be on the patient's right. Once again, I'm right down near the symphysis pubis. I should see a full bladder. And I sometimes like to fan all the way down till I can see the symphysis pubis on my screen. And then as you fan up, you'll see vaginal stripe, cervix, and then you should start to see body of the uterus. And you fan right through until you're out of the uterus. And then you're done. Sorry, I'm having trouble advancing my slide here. Did you see that video? Yeah, okay, awesome. Gonna try again here. I just got a frozen screen. Maybe I'll go to the next slide. Start from there. Okay. So we're going to talk about ruling in an intrauterine pregnancy. By ruling in an intrauterine pregnancy, you rule out an ectopic pregnancy, except in that subset of patients who've had fertility drugs or IVF. And in that group of patients, your risk of heterotopic pregnancy, so you have a pregnancy inside the uterus and outside the uterus, is 1 in 100. So in those patients, ruling in an intrauterine pregnancy does not necessarily rule out an ectopic, but for everybody else it does. So you'll be taught this in EDI or any sort of fast ultrasound course that you take. You want to identify the bladder. Next to the bladder or juxtaposed to the bladder, you want to see the uterus. Inside the uterus, you would like to see an anechoic structure called the gestational sac. And then you'd also like to see a yolk sac plus or minus a fetal pole. In this picture, you can see the gestational sac, the yolk sac, and the fetal pole. I will mention to you, if the uterus is retroverted, it might not necessarily be right adjacent to the bladder. So the teaching is it should be adjacent to the bladder, but that will only be true on anteverted uteruses. However, as you do many pelvic exams, you'll feel quite comfortable identifying the uterus.
Sorry, this is a really silly question, but on the previous image, can you point out which one is a yolk sac and which one is a gestational sac?
Okay, no problem. So I don't have a pointer, unfortunately, but you see the two bars that are measuring the fetal pole? In this image?
Yes, we do.
Okay, so the fetal pole is within the gestational sac, which is that black round area.
Okay.
And right underneath the fetal pole is a little white circle. It's actually a disc. That white circle is the yolk sac.
Okay. Perfect. Thank you. Sorry.
Okay, so a couple of, thanks for that question, by the way. A couple of milestones that's good to keep in your head. So the gestational sac, that's the black area, will appear around 5 weeks gestation. The yolk sac, which is the little white circle in the black circle, will appear somewhere between 5 to 6 weeks. The fetal pole appears at 6 weeks, and then you should get cardiac activity around 7 weeks. So I'm just going to do a bit of a frame-by-frame walk through of some of the images in the video. So this is the symphysis pubis. You can see the 2 white bones with a black area in between. So that's the ligament of the symphysis pubis. And if you can orient your probe pointing all the way to the patient's feet and see this image, you know that you're low enough. So I sometimes like to start there just to make sure my probe is low enough, because the tendency is to put your probe up by the umbilicus and you're never going to see anything. Okay, so fanning up, fanning or sweeping up towards the patient's head, you will see the bladder, which is anterior, and distal to that, you'll see vaginal stripe, or in this case, I fanned up and I'm seeing cervix. Just like a CT scan, the patient's right is on screen left and patient's left is on screen right. Then you continue fanning up, you'll see bladder at the front, and then you'll see body of the uterus, and hopefully, if they're pregnant, you'll see a gestational sac, which is the black circle inside the uterus. As you fan up further, you might see, if they're 6 or 7 weeks, a fetal pole. You can measure the fetal pole to get a sense of how far along this pregnancy is. And the way that you do that is you zoom in, as this picture shows, till you have the fetal pole as big as you can get it in the middle of the screen. You then freeze it and you press your calx button. All machines have a calx button, whether they're called calc or there's a little picture of a ruler and a hammer, there will be a calx button. And as long as you are in the obstetrical preset, crown rump length should come up, and you can press CRL and then place one of your calipers on one end of the bean and the other caliper on the other end of the bean, and your machine should spit out a date for you. It'll say this crown rump length is 6 weeks, 1 day. What you want to try and do is get the longest bean length that you can. So sometimes that means rotating the probe just a little bit one way or a little bit the other way. Try and get the longest bean length that you can. So this is like a 12-week pregnancy. The other one was earlier, about 6 weeks. If you have a 12-week or 13-week pregnancy, then the fetus will, or the embryo will have a spine and a face and a profile. And if you can get it in profile, that's what you would like to do. Okay, this is a endovaginal picture, and you can tell because the field of view is 120 degrees. So it's a wider field of view with an endovaginal probe, and the pictures are a little cleaner, as you can see from this image. So this is like a 7-week embryo in profile. Spine is at the bottom, and you can see the yolk sac at the top left-hand corner. And so that's just another example of embryo in profile. And that is very easy to measure from the crown, which is the top of the head, down to the rump, which is at the bottom of the spine. Okay, I want to talk a little bit about myometrial mantle. So when you identify a pregnancy, hopefully in the uterus, so you identify a black area in the uterus, and then there's a little white circle, which is your yolk sac, and then you might have a fetal pole, and then that fetal pole might even have a heartbeat. You have to make sure that there's enough uterus surrounding your pregnancy to call it intrauterine. And so that number is about 5 to 8 millimeters. In this image, you can see that there is an anechoic structure. It's got a fetal pole in it. If it were live, you might even see a fetal heart. But I'm hoping you can appreciate that structure is not within the uterus. And so this is an ectopic pregnancy. So don't get waylaid by a fetal pole with a fetal heart. It must be inside the uterus, which is why we talk about a gestational sac in the uterus, a yolk sac in the uterus, and then you need a myometrial mantle of 5 to 8 millimeters. So if you look at this image, this is a 6-week, 5-day pregnancy. And I've measured the fetal pole, and you can look at the myometrial mantle. So that's that area from the gestational sac to the outside of the uterus. It's 23 millimeters. It's huge. So that's great. That pregnancy is inside the uterus and is safely surrounded by endomyometrium. Now, this pregnancy, so the uterus is labeled there for you. It's an endovaginal ultrasound. You can tell by the wide field of view. Gestational sac is over to screen right, which is that black circle. And inside the black circle, you see a little white area. That's the fetal pole. But I hope you can appreciate there's not a lot of endomyometrium surrounding that black circle. And in fact, if you were to measure it, it's only about 3 millimeters. So this is an interstitial ectopic pregnancy. All you need to know really is it's not an IUP as per our criteria. It is not surrounded by enough myometrial mantle to call it an intrauterine pregnancy. And actually, this pregnancy is the most at-risk pregnancy. An interstitial ectopic pregnancy is the riskiest because they tend to grow quite large before they burst. And when they burst, they're surrounded by quite a few vessels. So they bleed more than the ectopic type of, the tubal ectopic pregnancy. They are rare, however. This is another kind of eccentric gestational sac. So the gestational sac's kind of over to one side of the uterus. This is a bicornuate uterus, so there's kind of two cornua to the uterus, and the gestational sac is in one cornua. This video, by the way, is by Phil Pereira. He runs Sound Bites, highly recommended. So there's the gestational sac, there's the yolk sac, and when they measure the myometrial mantle, it's 5.6 millimeters. This was a cornual pregnancy, what we call a cornual pregnancy. It went on to be a viable pregnancy, but it's got a borderline myometrial mantle. So it's got borderline tissue around it. And you need to seek obstetrical consultation and high-level ultrasound if you see a thin myometrial mantle like that. Okay. So another question I came across after I was doing quite a few of these is, well, what if all I see is a gestational sac? And this has been looked at, the accuracy of first trimester ultrasound when you only see a gestational sac and you can't find a yolk sac or a fetal pole. So there's that time between 5 and 6 weeks when you can have a normal pregnancy and this happens. By EDI teaching or any first trimester ultrasound teaching, you want to have a gestational sac and a yolk sac. And the reason for that is the positive predictive value of an IUP, if you see both of those things, is 100%. If you only see a gestational sac, the positive predictive value of an IUP is 96%. It's still pretty good, but it's not 100%, which is what you're looking for. And the reason we talk about this is sometimes you can have an ectopic pregnancy and a pseudo-gestational sac. So a pseudo-gestational sac is not the same as a gestational sac, and you can see it in ectopic pregnancy. So if you see only a gestational sac and the patient is stable, it would be reasonable, if you don't have easy access to formal ultrasound, to bring them back in about 3 or 4 days, and by then they will have developed a yolk sac. What about the scenario that you might also come across where there's no yolk sac and the gestational sac is really large? So if you have a mean sac diameter of greater than 25 millimeters, then that's a blighted ovum. And unfortunately, that is an inevitable abortion. That's a criteria for pregnancy loss. And you might say, okay, the gestational sac looks really big and I don't see a yolk sac. Maybe it's a blighted ovum. How do I measure that? How do I know that? So you can measure it. And here's how you do that. So in sagittal section, so with the probe pointing up and down, you can freeze your image and measure in your calcs gestational sac from top to bottom and front to back. And the computer will take those measurements. Then you can unfreeze, turn your probe sideways, and measure from side to side. And the computer will, or the application will spit out a mean sac diameter. In this case, at the top of the screen, you can say it's 5 weeks, 0 days. Okay, so I just wanted to share with you, there are a couple of criteria for pregnancy loss. I'm not going to talk about the bottom two because those are followed over several days. But when you see someone at point of care, if the heart rate, or if there's no heart rate when the crown rump length is above 7 millimeters, that is usually a pregnancy loss. And I'm just giving you this information so you have an idea and you can share this information with your patient. So if the crown rump length is 25 millimeters, you know, if they have a 10-week fetus in there and there's no fetal heart rate, it's highly unlikely that they have a viable pregnancy. And in fact, you know, criteria at high level ultrasound is if their crown rump length is above 7 millimeters and there's no fetal heart, then that's a pregnancy loss. And then we just talked about the large gestational sac. So a mean sac diameter greater than 25 millimeters with no embryo is also pregnancy loss.
Can I ask a quick question?
Sure, please.
So for the heart rate, say you have the crown rump length like 8 millimeters, does it matter like what ultrasound you're using in terms of resolution? I'm just thinking like there's so many, you could have the phone attached ones, I think they're called like Butterfly or something. Do those have enough resolution to be able to, you know, see a heart rate? Is there any ultrasound you wouldn't trust to assess this, or?
It's really operator dependent. So most of the images I've shared with you today were done with a handheld ultrasound, Clarius, onto my phone. So it's just a matter of getting used to the application and making sure, you know, you've done enough of them to really be comfortable measuring the crown rump length. So if you've only, you know, measured a few crown rump lengths and you get 8 millimeters, I wouldn't go telling that person, oh, you have a fetal demise, right? You have to accept that there's going to be some level of error when you first start measuring crown rump length. So I'm giving you the diagnostic criteria, and it's not dependent on the ultrasound you're using. It's dependent on you, the ultrasonographer. So if the crown rump length is really large, like 25 millimeters, I think you can be confident that's a big fudge factor. that, if there's no fetal heart rate there, it's a pregnancy loss. But I wouldn't go making that call, obviously, at 8 millimeters yourself.
Yeah, thanks.
Okay, so measuring fetal heart rate. You need to do this in M mode. So all machines, even the little handhelds, have an M mode. That's motion mode. You put it in M mode. You take that little bar and you put the bar over the fetal heart rate. And when you do that, the screen down below will start to move and you'll get little dashes showing up. And this is the fetal heart rate. And once you can discern the little dashes, where they start and where they stop, you can freeze the screen and you put one marker at the beginning of a dash and the next marker at the same place in the phase in the cycle. So here my 2 blue lines are at the end of the dashes. And then the application will spit out a heart rate for you. In this case, it's 171. I've chosen to show this M mode picture. This is like a 20-week fetus, so you can see the heart's huge. It's easy to put the marker over the heart. And when you look at the readout, it's much easier to see the dashes. So when I look at this image, I can easily see the dashes of the fetal heart rate, but I can appreciate if you haven't done this very much, you might not be so clear where the dashes are. But if you do a few, then you'll start to see them. And this one is more clear.
Sorry, I just have a question. We cannot do this in freeze mode. It has to be the ultrasound on, yeah?
Yeah, so you go into M mode, and when you put your marker over the fetal heart, you're not in freeze mode. But then you need to freeze it before you measure it. So once you're happy that, oh yeah, I can see the fetal heart on that screen, then you freeze it, then you take your bars and measure it. Do you get that?
Yes, thank you.
Okay. Yeah, so I just included this slide because it's a little bit easier to read. Fetal heart rate's only about 128 instead of 171, and you can see the bars more clearly. Okay. A fetal heart rate greater than 110 beats per minute is very reassuring. And this is the part where I'm usually most gratified when I see someone with first trimester bleeding. Because you can reassure people when you put that ultrasound on and there's a little embryo that's wriggling around and the fetal heart rate is 130, automatically their miscarriage rate has dropped to 5%. That is very reassuring for people, and it's really nice information to share with them. Okay, can you do this safely? We've covered a lot of information today, probably more than you would get in a fast lecture. But as I said, I have a great affinity for this patient population, and I would like to be able for you to share as much information with them as you can acquire with the ultrasound. There was a study way back in 2009, actually looking at diagnostic accuracy of emergency department physicians in first trimester ultrasound. And the specificity exceeded 98%, sensitivity exceeded 90%. So, you can do this safely. I would encourage you, like I said in the beginning, to stay humble and curious and practice as much as you can. But do not forget that IUPs can be detected at 5.5 weeks of pregnancy. So you don't need to wait till they're 7 or 8 or 9 or 10 to throw that ultrasound on there. Throw it on there if they have a first trimester bleed. And just to remind people that many of these women are anxious, and you can shed some light into their life and you should take every opportunity to do so. We do have a little bit of time, so I wanted to just briefly talk about the Rh negative patient and do they need RhoGAM? And so it depends who you ask. So our Canadian SOGC recommends that you give RhoGAM for pregnancies greater than 7 weeks based on not very good evidence, 3C. And if you look at the American Obstetrics and Gynecology Society, they say RhoGAM administration to a patient with threatened abortion prior to 12 weeks gestation is controversial and no evidence-based recommendation can be made. So they're like, there's no evidence that you need to give RhoGAM and there's no evidence against it. So just make your best decision. And then the NICE guidelines, which are the UK National Institute of Clinical Evidence guidelines, recommend that you do not offer RhoGAM to women with threatened miscarriage unless surgical management is undertaken. So I just wanted to share that with you. Often you're like, do I give RhoGAM? Do I not give RhoGAM? The official Canadian line from the SOGC is if they're greater than 7 weeks, you should, but there is lots of evidence out there saying that might not be the best idea. So my name is Virginia Robinson. There's my email. There's my phone number. If you have a Clarius or a butterfly and you're not sure what you're looking at, you can always bring me into your ultrasound screen and I'm happy to help you out. I don't always answer my phone at 2 o'clock in the morning, but you would be surprised. You might get someone on the end of the line anyway. And feel free to contact me. Okay, I'm going to take questions.
I was just asking on the chat, is there any harm in giving RhoGAM?
So, you know, it is a blood product and the chance of harm seems pretty low. But it's there because it is a blood product. So there could be some communicable disease that we don't know about that's floating around there. So it's not without harm, but there's pretty low risk for sure. Okay. Sorry, I couldn't see the chat while I was presenting. Was there any comments from the, no?
I was just wondering, with measuring your myometrial mantle, is there a specific plane that you're measuring that in? And are you looking for the thinnest line and measuring that?
So really good question. So you always want to look at everything in 2 planes if you can. So like a sagittal and a transverse, or an oblique, or 2 planes. And you should measure them in both planes, but yes, you would be concerned about the thinnest one. And that's not to say necessarily that you have, you know, an interstitial ectopic pregnancy or a cornual pregnancy, but you would want to get a high-level ultrasound at that point if it doesn't meet your myometrial criteria of 5 to 8 millimeters.
Thanks.
So I'm not familiar with portable ultrasound. Just to quickly ask, we can share the images. Is that correct? What you're saying? Is that through Rudy or Mabel, or so, how would you do that?
So with Rudy and Mabel, that's 24-hour service, as you probably know, and we are certainly there to help. Not everybody has that's where the issue comes in, is different proprietorships. So not everybody has a butterfly or a Claris. So in those cases, you're often just holding your phone up to the cart-based ultrasound screen, and we can try and help you out through that. But if you have a Clarius, and do you see up there, there's a little telephone on the app. And if you press the telephone and put my phone number or my email in, I can look at your images live as you're scanning, and they're super clear. So that's a feature of Clarius. Butterfly also has that feature, and the images are also superb. The only problem with Butterfly is you have to be a Butterfly account holder to look at the images, whereas Clarius, you can call anybody. They can get an email to whatever account, and they can look at your images. And then I don't know Philips Lumify or the GEV scanner, what their options are. Does that answer your question?
It does. I guess thank you. Second question, do you have slightly related, any strong feelings one way or the other in terms of handheld portable personal ultrasounds, branding and suggestions?
You mean which of the handheld ultrasounds do I recommend or prefer?
Which do you prefer? Any that you'd recommend staying away from?
It depends on your budget. The Butterfly is the cheapest handheld ultrasound out there, and it's good. I think the Clarius ultrasound gives better images, but you're almost not doubling your price. I mean, you can get a Butterfly for about $4,500, but then you have to pay a subscription every year of $500. So it kind of cost averages out to the same as a Clarius in the end, but Clarius is going to cost you $6,500. And then the Philips and the GEV scanners are similarly priced. Philips Lumify, pretty good images. I still think Clarius has the best images. Oh, the only thing with Clarius though is, you know, you buy a C3 or you buy a phased array, whereas the Butterfly is all in one.
Does any of this get covered once you're a physician? Like, can you put it as an expense, or like, is it something with taxes, or are you on your own?
Yeah, no, it's all tax deductible for sure. So it's like buying any other ophthalmoscope or otoscope. It's a piece of medical equipment and you can absolutely expense it. That's completely legit. Yeah, I mean, there might be in the future, you know, some subsidization for probes. A lot of people are interested in getting rural doctors using probes, and I mean, rural CME. I think you can use rural CME for a probe. So there's subsidies potentially out there as well. There's a question about dating. And I personally do dating ultrasounds for my patients that have to travel a long way. So we just got ultrasound in Fernie about 2 months ago. Prior to that, it was 4 hours of driving to get your dating ultrasound. So I was doing dating ultrasounds in my community. I certainly think that's reasonable. But like all ultrasounds, you have to have some idea that you're competent at what you're doing. So what I did was I did 50 dating ultrasounds and sent them all for high-level diagnostic ultrasound. And after doing that, I was very comfortable that, you know, I could do a dating ultrasound. And so I do offer that to my patients. But there are no billing codes at this time for using POCUS in clinic. That is completely true. So I do it as a service to my patients so that they don't have to drive, but it is not presently compensated. Someone's got a V scan for sale. So if anybody would like any of the information, I'm happy to send people the information, my presenter notes or whatever, if you'd like me to share those. And I'm always open to feedback. Whenever I practice these things, they take an hour, and then when I do them, they take half an hour. So I think I kind of run through them, but I appreciate any feedback. Yeah, so I can send the notes through Bryden. Awesome. Any other questions? No.
Actually, I had one question. Can you save the photo, like, and put it into your EMR at all, or?
Okay. You can. So obviously it depends what you're using. It's a bit clunky if you've got a cart-based. So cart-based machines archive all your images. So you can definitely go and get the images. You press archive usually, and like all the studies that have been done. And then you have to export it to a USB, and then you can either print out your images or you can digitally send them to your EMR. The handhelds tend to have a reporting application that's a little bit smoother. So you can just send the images directly to wherever.
Would you recommend doing that? I'm just thinking, like, particularly in obstetrics, you have a lot of room for like litigation. Would you recommend saving the photos, or is it kind of like, oh, I just did this as a service to you, I don't really need to save it? You just counsel a patient that it's not 100%?
Well, so I guess it depends what you're doing. My dating ultrasounds, I do archive them, and I will send them or put them in the EMR. If you're just doing, is it bum down or head down, I don't think you need to archive that. If you're doing an amniotic fluid index, so third trimester ultrasound, I just write it on the chart usually, just because it's so clunky for us to, save it to a USB, put the USB in a computer, print the image, take the image. What do? You staple it to the chart. It's clunky. So in those cases, I usually put like POCUS, AFI, 3 centimeters, sent for formal ultrasound, rule out oligohydramnios, and I think, your charting, it holds up in court.
Right.
Mm-hmm.
Cool. Thanks.
That being said, one of the projects I'm working on is to try and get a province-wide archival system for all ultrasounds. It doesn't matter whether you're a butterfly or POCUS or whatever. And that is, it will help for archiving images and medical legal reasons, but it's also so that you can call up a specialist, and say, can you look at my, whatever this, gestational sac that looks kind of on the edge? And anyone will be able to go and look at your images. And so that's kind of in the works. And I would say it's probably 18 months away. Okay, great. Well, if there's no more questions, I think, do you guys have another session, or is this it? You're done? Or you have to leave and sign on somewhere else, maybe?
Yeah, we have to leave and sign on somewhere else.
Somewhere else. Okay. So I'll give you 14 minutes to grab a coffee or something. I'll stay on the line here for a few more minutes in case anyone decides they have other questions. I don't start working for another 14 minutes here, so. I'm happy if someone has something else they'd like to ask, but otherwise feel free to sign off. And good luck to everybody.
Thank you.
Much appreciated. Thank you very much.
You're welcome. Take care. Bye-bye.